Thank you, Dr. Vilesh, for the appreciating words. And at the outset, I would like to thank Vijayan sir and the ECNG group for giving me this opportunity. So, thank you once again, and we will directly go to the topic. I think I am quite audible, right?
Absolutely. Very clear and very nice. Yeah.
Thank you. Thank you. So, we'll directly go to the topic. The topic has already been mentioned. It's mastering ultrafiltration from challenges to the precision targets. So, we will navigate this topic based on these 5 aspects. The basics, like defining what is ultrafiltration and dry weight. What are the dangers associated with an imprecise ultrafiltration, whether it is an under ultrafiltration or an over filtration. And the challenges that we usually come across, the physiological as well as the technical hurdles. How to calculate the precision UF and what is the future. So we'll go through this in around 30 minutes. So first of all, what is ultrafiltration? So you all know ultrafiltration refers to the process of fluid removal from the bloodstream during hemodialysis. There are mainly 2 mechanisms by which this happens, either by a pressure control or a volumetric control system. We will discuss these about the technical aspects a little bit later. So why do we need to do an ultrafiltration? Our ultimate goal. What is our ultimate goal? We have to achieve a patient's dry weight. So we should know what is the dry weight. So a dry weight is the lowest weight a patient can achieve without developing symptoms of either hypovolemia, that is a decreased fluid in the body, or hypovolemia. So what are the common signs of hypovolemia? Like dizziness, you might get cramps, muscle cramps, hypertension, sometimes excessive thirst or excessive fatigue. All these are signs of hypovolemia, that there is a decreased fluid in the body. And when there is an increased fluid, you often feel edematous, tidal edema, sometimes associated with dyspnea and uncontrolled hypertension. So these are the common features of an excessive fluid in the patient's system. So both these symptoms should not be there if the patient achieves a dry weight. So it represents the normovolemic state where the extracellular fluid volume is minimized without causing a vascular collapse. So it's easy to define this, but there always lies a challenge. Dry weight is often a clinical estimation. It's not a definitive measurement. So we should know how to clinically assess the dry weight of the patient, and that is the most important thing in ultrafiltration, what I feel. Okay. So again, going into what happens when we underfiltrate or when too little of fluid is removed. So most importantly, congestion will happen. There will be increased fluid in the body leading to peripheral edema, pulmonary congestion, and this pulmonary congestion will lead on to increased risk of acute decompensated heart failure and pulmonary edema and increased hospitalization. Along with that, chronic hypervolemia will lead to chronic hypertension, volume-dependent hypertension, and especially that sort of hypertension is always difficult to treat with multiple patients on multiple antihypertensives. And what is the long-term effect? Patient will have effect on the cardiovascular as well as the CNS, cerebrovascular system. So patient will develop ventricular hypertrophy, increased cardiovascular and cerebrovascular morbidity and mortality. Also, already with pre-existing congestive heart failure, if patient is having cardiac issues, that will add on to the morbidity of these patients by increasing the preload. That increases the all around cardiovascular mortality. These are the usual problems when you don't remove the fluid properly. So what happens when excessive fluid is removed? When fluid removal is too rapid or excessive? The dangers of overfiltration. So most importantly, we might be coming across this issue, the intradialytic hypotension. So there's a significant drop in blood pressure during dialysis associated with symptoms like cramping, nausea and all. This will add on again to the cardiovascular morbidity, mainly by causing myocardial stenting. That happens as in the immediate period, there will be myocardial stenting that leads to cardiac muscle damage. Recurrent IVH can lead to cardiac muscle damage, and that leads on to long-term cardiac complications. Other than cardiovascular system, one of the most common complications that we come across is the complications associated with access. Like when you do an excessive ultrafiltration, when the patient becomes severely dehydrated, hemoconcentration happens, hypertension happens, that itself is a trigger for the thrombosis of the AV fistulas, that leading to loss of the vascular access. So access thrombosis is a notorious complication that we come across in dialysis. It's always difficult to manage the patients with poor access in dialysis. Then coming to the kidney aspects. So most of our patients will be anuric, but many patients will still have some urine output, like maybe 500 to 1000 ml per day. So that's what we call a residual kidney function. So what happens when there is a recurrent episodes of intradialytic hypertension? These residual kidney function will be lost and patient soon becomes anuric. This will add on again. Once the patient becomes anuric, that's a vicious cycle. The intradialytic weight gain and the fluid status of the patient increases. Along with that, other features of residual uremia will happen. So this is the main issue with when concerned with the kidneys. And also it has some effect in the cerebral or the CNS of the brain that causes white matter changes, progressive frontal lobe atrophy that leads on to dementia and increased risk of stroke. So proper ultrafiltration is important. We have already seen what will happen if not much fluid is removed, if excessive fluid is removed. Both these are both these causes a long-term complication to the patient. So that is the importance of a proper ultrafiltration. So what is the limiting factor here? What happens? What is the issue with ultrafiltration? So as we can see, we are removing fluid from the intravascular system, that is within the blood vessel. So fluid is being removed from the plasma. So as the fluid is removed from the plasma, the excess fluid that is usually accumulated in the dialysis patient in the interstitial space, like pedal edema and pulmonary edema and all. So these interstitial space fluid has to shift back into the intravascular system. That's the normal physiological mechanism. This is called a plasma refill rate. So as the fluid is removed from the plasma, fluid must shift from the interstitial space back into the capillaries. So what are the challenges that we face? One is, if the UF rate is more than this plasma refill rate, the intravascular volume drops too quickly. That leads to hypotension, the intradialytic hypotension. And what is the second challenge? This plasma refill rate is highly variable and it depends on so many factors. Most importantly, the cardiac function of the patient. If the patient is having some cardiac issues, LV dysfunction and all, this plasma refill rate will be low. Again, if the patient is malnourished, patient is having hypoalbuminemia, that will cause a decrease in the oncotic pressure and that will lead to decreased plasma refill. And one more is, if the patient is having some infection or sepsis or something, there will be an increased capillary permeability. More fluid will be escaping from the intravascular space again into this interstitial space. So increased capillary permeability. These all factors will reduce the plasma refill rate. And those patients with these complications have higher risk of intradialytic hypotension. Now, the technical determinants of ultrafiltration is mainly two things. The ultrafiltration coefficient of a dialyser, that depends on the dialyser type. Based on the dialyser type, each dialyser will have different ultrafiltration coefficient. And the second thing is the transmembrane pressure. That is the pressure gradient across the dialyser membrane. And it is set by your pump and flow sensors. These are the technical things that we will come across in next few slides. Now, before going to the technical thing, the most important thing clinically is the ultrafiltration rate. Most of the time we keep the ultrafiltration as 4 liters or 3 liters like that. Like for a 4-hour dialysis session, we'll keep at 3 liters, something like that. So more importantly, it is the ultrafiltration rate rather than the total ultrafiltration volume that is important. So always make a habit to keep the ultrafiltration at ml per hour, like 500 ml per hour or 600 ml per hour, whatever it is, depending on the intradialytic weight gain of the patient. Now see this graph. This is the ml per hour, that is the ultrafiltration rate is here, and this is the cardiovascular and the all-cause mortality of the patient. As we can see, up to 10 it's quite okay. After that, there is a slow rise, and after it reaches a level of 13, there is a sudden increase in the cardiovascular as well as all-cause mortality. So this is the important things, and this has been studied in these are the various studies that has in different points of time that has all been published in very important journals, and all these have shown that if the ultrafiltration rate is more than 13 ml per hour per kg, there is a steep rise in all-cause as well as the cardiovascular mortality of the patient. So suppose for a 50 kg patient, if we consider a cutoff of 13 ml, you can remove maximum of 650 ml per hour, or roughly 2.6 liters in a 4-hour usual dialysis session. If it is 70 kg, that will be around 910 ml, or in 4 hours, it's around 3.6 liters. So that is the maximum that you should remove from a patient in a 4-hour dialysis session. I know it will be difficult. Some of the patients will have intradialytic variant much more than that. You will be forced to remove more fluid than that. So when that happens, what you are supposed to do? So that we will discuss. So always remember this value. Keep a UF target of less than 30 ml per kg per hour. Now coming to the technological foundations, there are mainly two UF systems, UF control systems, the pressure control system and the volumetric control system. Pressure control system is the age-old and the older versions of dialysis where the ultrafiltration regulation is by manipulating the transmembrane pressure on the TMB. It's less accurate due to variables affecting the membrane permeability, especially like protein fouling that happens with the dialyzer and also the blood clotting. And historically, it's been associated with significant UF errors. To tide over that, there comes the volumetric control systems. It directly quantifies the volume of dialysate passing through the dialyzer, and it has got a superior adequacy, especially with high flux membranes, and essential for modern high precision hemodialysis. So these volumetric control system has changed the aspect of ultrafiltration in modern dialysis. So we will discuss about this volumetric ultrafiltration in this figure. You might be knowing about the balancing chambers. This is the dialyzer. This is the balancing chamber. So what happens is that balancing chamber contains a flexible membrane, and on one side there will be fresh dialysate coming, and on the other side there is a used dialysate coming. So if you can see this, if you can track this, this is the proportion dialysate that is coming to this balancing chamber. So once the fresh dialysate comes in this balancing chamber, this flexible membrane will push the used dialysate into the circuit. And the reverse also happens. Once the used dialysate comes here, it will push the fresh dialysate into the dialyzer. So for each volume of fresh dialysate comes, the used dialysate will be pushed out, and for each amount of used dialysate that has been coming, that will push the fresh dialysate in equal volumes. This is the mechanism that has been usually used in all dialysis apparatus now. So even that it will not have very much, it will be more specific than the pressure control system. So this is a closed circuit. How you do an ultrafiltration? You have an additional UF pump. UF pump is usually a piston type of pump that is kept on the dialyzer side of the circuit, and it will apply a negative pressure and remove the exact amount of fluid that you have kept as ultrafiltration. So from this circuit, the UF pump will remove say 100 ml, and that 100 ml will be added upon from either the fresh dialysate or the used dialysate. So this is how newer versions of dialyzer or the dialysis apparatus make sure that the amount of ultrafiltration that we have kept has been equally removed from the patient. So we will again go back to the slide. So these most dialysis machines uses this volumetric based control, which uses a balancing chamber composed of two compartments. It's separated by a flexible membrane. One side of the membrane allows fresh dialysate and the other allows spent or used dialysate out. Valves are connected on the inlet and outlet and allows fluid to enter one side of the chamber, which pushes an equal amount of fluid out of the other side of the chamber. So one chamber fills with used dialysate and pushes fresh dialysate to the dialyzer, while the other chamber is filling with fresh dialysate and pushes used dialysate to the drain. And the UF pump. The UF pump or the fluid removal pump removes fluid from this closed loop, which results in fluid removal from the dialyzer membrane. So most UF pumps are piston type and placed in the used dialysate flow path by a negative pressure. So when the UF pump is off, there is no pressure gradient between blood and the dialysate in the dialyzer, and so no fluid is removed from the patient. I think I am clear. We will discuss further if any confusions are there. And one more system is the volumetric control system, which is a flow control system. Here, instead of the balancing chambers, we are using the pre-dialyzer flow sensor to assess the amount of fluid, that is amount of dialysate that is going, and there is a post-dialyzer flow sensor that measures the used dialysate, and based on that the UF pump removes the amount of ultrafiltration that has been set. So this is a flow control system which uses a flow sensor. So both these are volumetric control systems. So how these volumetric control systems differs from the older pressure-driven UF control? Here the primary variable is volume. UF pump removes an exact measured volume per unit time, whereas previously the primary variable was pressure. Operator sets that TMB, and based on the TMB, UF will be removed accordingly. So mechanism, as we already discussed, the balancing chambers ensure precise inflow and outflow, and dedicated UF pump removes the prescribed UF volume. Whereas in older versions, it relies predominantly on relationship between the set TMB and the dialysis ultrafiltration coefficient that will be quite variable because of this protein fouling and floating and everything. And the role of TMB in newer versions, monitored and calculated automatically to achieve a volumetric UF rate, and that prevents unsafe conditions. Whereas in pressure, all the technical, okay, these are all the technical aspects that we have already discussed. I think I have completed this slide. Now, coming back to the clinical side, we are again going into the clinical aspects of ultrafiltration management. What are the core goals of ultrafiltration management? So this includes, most importantly, the 5 important things. One is accurate assessment of dry weight, individualized UF profiling depending on the patient's clinical condition, accurate dialysis prescription and technical modalities. Patient education is very important, and dietary management as well. And some patients may need some sort of pharmacological support. So coming to the dry weight assessment. So the most important aspect here is standardizing the weighing procedure. Use only medical grade scales, and even each and every variables associated with weighing the patient is important. That includes the timing, proper timing. Always make sure you measure the patient's weight just before cannulation or just before the initiation of dialysis, and after completion or immediate post-therapy weight after that. The timing is important. Then clothing. We prefer a light cloth. Sometimes what happens is, sometimes patients pre-weight, when checking the pre-weight, patient will have his wallet in his pocket. He might have having a heavy watch or something else. He might be having other mobiles and other gadgets with him, and he'll be weighing that. And sometimes what happens is during dialysis, he might be keeping all these things aside, and when checking the post-therapy weight, nothing will be there. This itself is enough to cause a change in the post-therapy weight by around 500 milligrams. So that is quite important. So always make sure these things before checking the weight. Then food. If a patient takes a lot of food during dialysis, that will have effect on the post-therapy weight. Then bladder, most of our patients will be anuric, but if patient is having a significant urine output, it's always preferable to measure pre-HT as well as post-HT weight after emptying the bladder. And if the patient is catheterized and is having a urobag, make sure the urobag is not calculated along with the weight of the patient. So these are simple things, yet in busy dialysis schedules, we might often forget all these simple things. So always make sure that our weighing procedure is standardized according to the medical standards. Now, if you check the weight, then the next important thing is have the patient achieve the dry weight. So post-ST, you are checking the weight, and we have to be sure whether the patient has achieved that dry weight. So we have already discussed patient should not have any features of hyper or hypovolemia. So for that, you check the edema. If patient should not have any edema. You should have a well-controlled hypertension or a well-controlled blood pressure. No signs of hypovolemia like cramps, dizziness, or hypertension. Then no features of fluid overload like no congested neck pains or elevated JVP. Or if you have, if you can auscultate, just make sure his chest is clear without any crepitation. And the general well-being of the patient. Even an excessive thirst or excessive fatigue post-ST is a sign of hypovolemia. So these are the usual clinical signs that we look for to check whether the patient has achieved the dry weight. So that's what I told, that always this dry weight is a challenge because it's a clinical judgment rather than a definitive measurement. So there are some aspects, there are some advanced technological tools that helps us in identifying the dry weight of this patient. That includes bioimpedance spectroscopy, blood volume monitoring. Some advanced Fresenius machines have related blood volume monitoring in line. Then IVC collapsibility using an ultrasound. Doctor, and sometimes the natriuretic peptides pre and post-ST has been done. But these are not much practical when you do in a dialysis center or in a routine OPDs. So sometimes some patients, especially high-risk patients, especially doing dialysis in a hospital, sometimes this may be helpful, but you can't generalize these things to all the dialysis population. Still, if there is a problem with the clinical assessment, we can depend on this, but these are all not being used widely. It's more importantly used in the study purposes and all. So might be in future we might be using all these to assess the dry weight of the patient. Now coming to the individualized UF profiling. So what we usually do, we do a constant UF profile. Like patient comes with a 3 liter of weight gain, you're keeping 3 liters for 4 hours, like 750 ml per hour. That's the usual standard procedure. It's simple, but can be problematic for patients, especially with increased risk of intradialytic hypotension. So we can use a stepwise UF profile, that is UF rate high at the beginning and gradually decreasing. So what's the physiology behind it? We already discussed about the plasma refill rate, the amount of fluid that shifts from interstitial space into the intravascular space. So during the initial period, patient will be a little bit in the volume overload state, and this plasma refill will be very fast. So there is very little risk of hypotension during the initial phases. So we can keep the UF at a higher rate during the initial process and slowly come down to lower levels when the plasma refill rate is minimum. So this is called the stepwise or the ultrafiltration profiling. Most of the machines like Nipo, procedures, whatever it is, will have this. You can see the graph that shows stepwise US profiles. Different US profiles are there. So this is one of the US profiles that is commonly being used in patients with intradialytic hypertension. Keep UF rate high in the beginning and slowly come down. Then along with that, you can do a sodium profiling in conjunction with UF, like using a higher dialysate sodium at the beginning to maintain that plasma refilling, then gradually decreasing to avoid positive sodium balance and post-dialysis thirst. That is, like again, the plasma refilling depends on the solute concentration also. So if you have a high sodium, that plasma refill will be faster because water flows from an area of lower solute concentration to high solute concentration. So that plasma refill will be more if the dialysate sodium is kept a little bit high. But when you keep that dialysate sodium towards the end also high, what happens? The sodium load of the patient increases and there will be a positive sodium balance. So what happens when there is a positive sodium balance? Patient will have increased thirst, patient will have increased intradialytic weight gain. Again, the next time patient coming will have increased fluid, so that you have to ultrafiltrate more. So that is the problem when you do a sodium profiling with sodium high in the end. Now, after that, you should have an accurate dialysis prescription and other technical modalities. So we already discussed about this 13 ml per kg per hour. So most of these patients will have, so if we keep a 13 ml per kg at cutoff, for a 50 to 70 kg patient, you can maximum remove around 2 to 3.5 liters. So many patients will come with the 4 or 4.5 liters weight gain. That is not recommended, but still that happens. So what we can do? The easiest or the most effective strategy is you extend the treatment time. If you're doing a 4-hour dialysis session, you can extend up to 5 or 6 hours. So that the UF rate is kept less than around 10 to 13 ml per kg per hour. So that is the extended treatment time. The next is cool dialysate. When you lower the dialysate temperature, that causes the peripheral vasoconstriction, increase the vascular resistance, and that also helps to maintain BP. So cooling the dialysate temperature to 35 or 35.5 or 36, if patient doesn't have any chills, and can also help maintain the BP. Now the third thing is, if there is a huge amount of fluid that you have to remove, then we can think of an isolated ultrafiltration. Like we can do a 4-hour normal dialysis with a UF rate less than 30 and keep 1 or 2 hours extra for isolated ultrafiltration alone. Why? Because isolated ultrafiltration, the risk of intradialytic hypotension is less when compared to the ultrafiltration when you are doing along with the dialysis. This is because during dialysis, the solute removal also happens. Urea and sodium, or these osmotically active substances will be removed. So that will reduce the plasma oncotic pressure and that increases the risk of hypotension. When you do only isolated ultrafiltration, you are only removing the fluid and some sort of convective clearance will be happening, but that's very much less than the diffusive clearance. So isolated ultrafiltration, the risk of hypotension is less compared to ultrafiltration along with the dialysis. So we can consider an isolated ultrafiltration. And if other modalities like hemodiafiltration can be done in patients with very high risk of hypotension. And in ICUs, we might be saying those patients with cardiac failure and hypertension or shock, we'll be doing continuous venous hemodiafiltration and all CRRTs and all. These mainly uses the conductive therapies of ultrafiltration. So these are the dialysis prescription changes that we can make to make sure that the BP is maintained along the course of dialysis. The most important thing next is patient education and dietary management. Ideal fluid intradialytic weight gain that is recommended is usually less than 4% of dry weight. That accounts to around 2 to 3.2 kg for around 50 to 70 kg adult. So you have to tell the patient to have fluid restriction. That is the most important thing concerning the ultrafiltration issues that usually face in clinical scenario. Then sodium restriction to less than 2 grams per day. And self-monitoring. Ask the patient to weigh daily and see for increase in weight. Like if you're doing a thrice weekly dialysis, immediately on the day of dialysis at night you can check the BP. Next evening you can see how much weight is increasing. If it is more than our target, they can quickly reduce the intake of fluid and thus reduce the risk of fluid overload. And also mention about the early signs of fluid overload, how to recognize early signs of fluid overload and reduce the fluid and sodium intake. And also educate on the role of excessive intradialytic weight gain. What happens if there is an excessive intradialytic weight gain? How the longevity of the patient is affected? How the morbidity and mortality increases? And if we can explain all these things to patients, patients will be more compliant to diet and fluid restrictions. So patient education and dietary management is also very important. And sometimes pharmacological support also. So about one thing about antihypertensive dose adjustment, never give a blanket statement to all patients to skip all the antihypertensives on the day of dialysis. But most of the patients will have uncontrolled hypertension. So if you skip that, the patients have higher risk of developing an acute pulmonary edema. And some of the medications that we commonly use, like clonidine, the central asa agonist, these medicines have some problem. If the patient is taking regularly that medication, if you skip one dose, that will produce a rebound hypertension. So that is most of the time we come across with that, and patient will have very high BP. So when these patients are taking this clonidine and all, don't ask to skip at all, like completely. Like ask them to skip if there is a risk of intradialytic hypertension, then ask the patient to skip take that into half. Like if he is taking 100, ask him to take 50. Even with 50, if there is a hypertension, then we can slowly wean off that. And step by step, if the patient is on 3 or 4 antihypertensives, you skip one antihypertensive, then if the BP is still low, then you can, in the next dialysis, you can stick another one, like that. Step by step decrease in the dose of antihypertensives may be done. Then in some patients, especially with autonomic dysfunction, with refractory intradialytic hypotension, we can give midodrine. Midodrine is a tablet that is usually given around 1 hour prior to dialysis. Usual dosage is around 10 milligrams. That is usually used in patients with refractory intradialytic hypotension. And about the dialysate potassium, if the patient have no risk of hyperkalemia, patients' monthly investigations, routine investigations that we follow do not have much hyperkalemia risk. If feasible, we can keep the dialysate potassium at 3 millicolumn per liter, high potassium dialysis. It's not typically a high potassium, but 3 millicolumn per liter can help in some patients with recurrent IDH. And also avoiding food during dialysis, especially in patients with recurrent IDH. Ask the patient to avoid food during dialysis, because when you eat the food, that leads to increase in the splanchnic circulation, and that can lead on to hypotension. So these are some of the pharmacological and other methods to avoid intradialytic hypotension. So in a nutshell, to summarize, our aim is to achieve a dry weight where there are no symptoms of fluid overload or hypovolemia, but always make sure to keep a UF rate less than 30 nml per kg per hour. And based on our newer volumetric based ultrafiltration, the accuracy and safety is very high. And clinically, you have to accurate dry weight assessment is essential. Individualized UF profiling can be done in selected patients. And dietary management, fluid and sodium restriction and self-monitoring is important. And in high-risk patients, we can try a pharmacological support also. Thank you.